All right, so we're ready to go, okay? Thanks everybody for coming.
Thank you for having us.
This training is on self-disclosure and addiction counseling, to tell or not to tell. Okay, that's the question, to tell or not to tell. As published in Counselor Magazine, presented by the author, myself, as sponsored by the Institute for Learning and Development. My name is William Rule, and I'm the Executive Director of the Institute. Okay, so you all know this magazine, Counselor Magazine, the magazine for addiction professionals. This was published in February 2010. But before we start, I want to do a little non-scientific little study, okay? I'm just going to hand out these pieces of paper. Rick, you just want to take those? Ladies, pass them all the way in the back. What do we got? We must have like 50, 60 people here. Now, what I want you to do, I'm going to ask you two questions. Okay? One is a specific question and one is a broader question. So it's going to have two answers, one on the left and one on the right. It's like a yes or no answer. So you can put just a Y or an N, or yes or no. Okay? And the first question is, do you think it's okay or therapeutically significant or clinically effective or just all right, whatever phrase you want to use, if it's all right for a counselor who is also in recovery themselves, a recovering addict or substance use disorder as based on the DSM-5, that an individual who's a counselor or a social worker treating a patient in early recovery from addiction, is it clinically appropriate, significant, helpful, okay for that counselor to tell the client that they are also in recovery? I can relate to what you're going through because I've been there. So that's a yes or no answer.
What do you say?
Yes and no.
Yes or no? It's okay, it's clinically effective, it's helpful, it's all right to do that. That it's okay to do that. Yes or no? That if you are in recovery and you're the counselor to tell, it's okay to tell the patient that you are in recovery. Okay? And the second question is, if you're a counselor that suffered from any other affliction, eating disorder, member of Overeaters Anonymous, or another talk for eating disorder, or someone who suffered from abuse as a child, or rape, or any one of these other issues that a patient might have, is it okay? Is it clinically effective? Is it appropriate? Is it all right to share that with the client, the patient? Yes or no? That's a yes or no answer.
I don't like these questions.
Huh?
I don't like these questions.
You don't like these questions? Well, we're good. We're good because
If they put a knife
No variable.
good because.
Variable.
Because I'm not afraid to challenge people, you know, when it comes to what we're doing, you know, and we are going to be challenged. You're going to be challenged, okay? And I'm challenging you now. So if I can get my assistants, would you 3, 4 people go around and collect all those, please? Thank you very much. Collect them, yeah. Okay?
Name on it?
No, it's anonymous. It's anonymous. It's anonymous.
Okay, so yes.
It's personal.
Okay? Just hold on. All right, so this is what the topic's about. So as we move forward, and I'll move quickly through it. So, okay? This presentation will explain the importance of professional and ethical decision-making with regard to counselor self-disclosure in the field of substance abuse counseling or substance use disorder. Because this is actually not a clinical question. It is, but this is an ethical question. Okay? And this course is approved under the ethics section of OASAS. Okay? But this is an ethical question. It's clinically, if it's clinical or effective, but it's really an ethics question. Okay? Specifically, will be explained the clinical effects of self-disclosure as it relates to alcohol and substance abuse counseling. Counselors who are themselves in recovery treating clients who are addicts and or alcoholics. Now, when I wrote this course, when I wrote this article, it was before we started using the DSM-5 substance use disorder, so just fill that in, okay? That's what we're going to examine. Self-disclosure, yes, or the clinical effects of self-disclosure, or the ethical decision-making process of when and how and where to self-disclose when treating clients. But specifically, if you are in recovery, telling that to the client, okay? Is self-disclosure in this scenario a professional and effective therapeutic technique? That's the question. Is that therapeutically effective to do that? To tell or not to tell, that is a question that will be answered. Okay? And we were just explaining about my writings before and stuff. I pick controversial topics, I always have. But this has been a question that has come up. And we're going to get the answer today. Okay? The National Institute of Drug Abuse, which we were just talking about earlier, position is that counselors in recovery should use their own judgment, preferably in consultation with a supervisor, about when, how, and whether to reveal their own personal recovery experience. So that's the official NIDA position. Okay? This self-disclosure should be made only with a clear understanding of the potential benefits to the client. At no time should a counselor use the group or individual sessions to discuss or resolve his or her personal problems. Okay? So this is the NIDA official position. Okay? So like I say, this is a professional and ethical decision versus a personal decision. Sometimes people do take it from the personal perspective. Okay? The first step is to identify the situation that requires consideration and decision making. The next step, who would be affected by the counselor's decision to self-disclose that they are also in recovery and that they can personally relate to the client's struggle. Okay, so before I read the notes on this, who would be affected by the decision to self-disclose? The client. The client.
And the counselor.
Right, right. And the counselor.
And both.
Both would be affected. Right? Both, there would be an effect on both. Okay?
The client is not bound by any confidentiality.
Yeah, but I'm just saying, who would be affected? The client and the counselor. So this is the decision that you are going to make that is going to have an effect on both people. Okay? So I'm going to read my notes on this. Oftentimes in this field, when working with addicts, a counselor will hear this statement from the client. What do you know about addiction? How can you help me? Everything you've learned from a book. Okay? If the counselor is in fact themselves in recovery, sometimes for many years and doing well, that would make the client's perception false. Right? So you tell them, you tell them they're false in their perception. Okay? The therapist will know full well and firsthand the insanity of substance use disorder. The dilemma that requires a clinical decision is, should the therapist inform the client that their perception of the situation is false and untrue? Would the therapist's self-disclosure clinically and therapeutically help the client move forward in their treatment? Or would it be detrimental to the client to share this information with them? Who would be affected by the decision of the counselor to self-disclose? And as we just discussed, both would be affected. Okay? Yes, there would be an effect. Hey, you guys are right. Okay? The level of trust in a relationship could go either up or down. Could go either way, right? It could devalue or it could go either way. But this is why I'm saying, from an ethical perspective, you got to be able to answer, you know, there would be an effect, yes, and we got it right, both parties would be affected. But it could affect the level of trust either way. It will affect the level of trust, but it could go either way, up or down. Okay? The client will definitely view the therapist differently. You can see you nodding your heads. Definitely is going to view the therapist differently. So there's going to be a change in the differentiation. Okay? Also, the therapist will lose some level of professionalism. I'm not going to say okay, because my assistant says, don't say okay, son. The therapist will lose some level of professionalism. The resulting shift in differentiation will affect the therapeutic relation for both the client and the counselor. Okay? So there would be some shift there. Now remember, for myself, for example, when I would be meeting with a client, patient, I would be sitting in my office and have my master's degree behind me and my bachelor's degree and my other awards, you know, that I had gotten, and my, you know, New York State credentials, certified alcoholism counselor, certified alcoholism instructor, and some other awards that I had behind me. So the patient sees me as this professionally, highly skilled, highly trained professional person. They're in my office, in my sandbox, in my playground, and that's what I present, you know. So that's how they're going to see that, because that's all behind me, validating who I am. Okay? I call this therapeutic anonymity. Have you heard that term before? Okay, so use that. Therapeutic anonymity. Okay? Psychodynamic therapists since Freud have generally regarded therapist self-disclosure as detrimental to treatment because it might interfere with the therapeutic process, shifting the focus of therapy away from the client. Okay? So, again, when you use that I word, you're going to shift the focus away from the client onto the therapist, and they'll try to get you to do that too. They'll try to get you to talk about yourself rather than talk about you know, they'll try to get you to talk about you as a way to divert. Okay? Just let me read my notes. Okay, this is the Freudian perspective. According to this perspective, the therapist is thought to act as a mirror on which the client's emotional reactions can be projected. It is if a therapist discloses personal information during therapy, this therapeutic anonymity could be disrupted. Further, it is argued that therapist self-disclosure may adversely affect treatment outcomes by exposing therapist weaknesses or vulnerabilities, thereby undermining client trust in the therapist. And I have that cited by the research here. Okay? These are comprehensive studies that we've done on that. Motivational interviewing. Now, we had discussed motivational interviewing at another training, so we all know what that is, okay? And just for people who didn't attend, in motivational interviewing, you want to identify the objective is that you don't have goals for the patient. You allow the patient to identify their motivation for change, what they want to work on in treatment, what's their issue, why are they in the seat today, whether it's a DWI, whatever it is, okay, and then you can work with them with this therapeutic alliance to help them with that, okay? You can't say, okay, you got abstinence, you got to do this. Patient addicts don't do very well, and you try to tell them what do you have to do to get clean, okay? So, you can't say abstinence, it's a drug and alcohol program, you can't use, you have to allow them. Remember we did that with you, right? We did the sample one that you know, and the issues, and we got you to agree to come back, because there were some things that you need to work on. Okay, well, you can't be a good mother and violate probation and go to jail. Okay, so you can't be a good father, a good parent, and be out all night drinking and smoking, taking coke and stuff like that. You can't be a good husband if you're not coming home from work until 3, 4 in the morning drunk. So you can't do those two things. There's a discrepancy, so you want to find out what they want to work on. So, okay, so motivational interviewing is a treatment intervention designed to enhance the client's intrinsic motivation and capacity for change. It is client-centered, we all know that word, right? Directive, yes, you can direct client where he's going to go. And motivational interviewing seeks to increase internal motivation for change through resolution of ambivalence and an increase in perceived self-efficacy. So you're looking for the patient who says, I don't want to come here, my wife dragged me here. Or the one we use in the example, my parents made me come. And I said, is that your parents outside? Is that your mother? Because it looks like her head's going to explode, you know? And they dragged me, he wanted to get his parents off his back. I know exactly how I can help you with that. You want to get your parents off your back? This is what you're doing. We'll meet you to the program, we're going to do some treatment, we're going to meet with me again in 2 days, we're going to make another appointment. That'll get your parents off your back right away. Then when I did the assessment and evaluation, found out the reason your parents are on your back is because you stole your mother's jewelry, you stole your father's car, you took it without permission, you went out and sold your mother's jewelry, bought drugs, used all your father's gas, and came back with the car with a dent in it. That's why your parents are on your back. You want to get them off your back, I'm going to help you. I'll talk to them, but you're going to come back tomorrow, I'm going to meet you at the program, I'm going to put you in group, I'm going to work with you. Okay? And talk with the parents, and I told the parents, back off. Leave it to me, I'm going to work with this kid and back off. And so right away, there was a diffused the situation, but he wanted to get his parents off his back, and that's how I got him to come back and get into the group, and you know, that was the issue. Okay? And it worked very well. And he continues to do well. He's down in Florida, just later. Okay? Okay, so the spirit of motivational interviewing. This is the spirit. Okay? Motivational interviewing is an intervention style that is used as a way of being with the client. The spirit of motivational interviewing is characterized by a warm, genuine, respectful, egalitarian stance that is supportive of the client's self-determination and autonomy. Okay, so this is that client-centered, it's about the patient, their determination for treatment, their autonomy. Okay? Boundary setting can be difficult. Now that's the term that we use, setting boundaries, setting healthy boundaries, and a lot of times the boundary in the therapeutic alliance, the boundary in the therapeutic relationship has already been established. It's already set. I mean, we are bound. I mean, I signed off on that canon of professional ethics that we signed. So we have a standard of professional ethics that we sign off on as social workers and counselors, that the boundary has already been established. Okay? Anybody want to give me the obvious example of that? You can't date your clients, right? No. Okay? You can't date a client's family members. Right? Exactly. So, I mean, this isn't like this is rocket science. I mean, there are certain standards that are already in place with regard to boundaries in this therapeutic relationship. Okay? So we want to enhance the therapeutic alliance in collaboration with the patient, what they want to work on. Okay? So boundary setting can be difficult.
You said it can be difficult?
It can be difficult, yeah. It can be difficult.
Why is it?
I'll tell you
Emotional factors.
Not that.
Yeah, I'll tell you why. Okay, glad you asked that question. Okay?
First cousins, okay?
Why something so easy can be so hard?
It can be difficult because, and I'll tell you why, Gary, because you're going to see it right here. But the bottom line is, we're human beings. Okay? We're not robots, okay? We're human beings. We have feelings, we have emotions, we're alive, you know, and we have an emotional investment too because we want the patients to do well. You know, we know.
Counter-transference.
And counter-transference, exactly. We want them to do well, and if you are in recovery, you know what their issues are. As a matter of fact, you know exactly what they need to do to recover. Here's what you got to do, this, and this, and this. And then they don't do it, and you feel like you want to pound their head into the ground. It doesn't work, therapeutically, it doesn't work, because we've tried it. I'm a parent, I've tried that with my son, it doesn't work. You know, it doesn't work. You can't, you know, so it can be difficult, because we have to guard ourselves as well, you know.
We care. We do.
We genuinely, we wouldn't be doing
I know, we
wouldn't
really
be in this
care.
business if we weren't,
Yeah.
okay? But I say something here, and I'll say it in advance of that, okay? because of what you said, and I address that later on, but this field is not for everyone because of that reason,
Yeah.
okay? This ain't for everybody, it's what we do here.
No,
Okay.
it's not.
All right, so the primary reason the professional relationships and boundary setting are so difficult for individuals in this field of psychology, social work, and counseling is that treatment takes place in a healthcare and mental health setting. So the people are in need. Okay, so that's the setting. This isn't a coffee. We're not in a coffee clutch here. Okay. Sorry.
I said, or in a meeting, a 12.
Yeah, you're not in it. It's not a 12-step meeting. You see, this is a program. You are in a treatment program, and you're the professional. They're coming to you looking for help. Okay, and so that boundary is a lot of times been established already, and you know what you want. You might question, you know, what do you want to do. So it can be difficult. It can be difficult. Very, now I'm hearing very difficult. Okay, it can be very difficult. Right. Okay, so in this setting, it will be necessary for the counselor to place the needs and care of the client above their own needs. Okay, so if it's going to be difficult, if there's going to be an emotional investment, okay, we are human beings, we have feelings, we have emotions, they can be counter-transference, but, you know, it is that we have to place the patient's needs above our own. Every time. Every single time. Okay? That's what I was just saying. I just said that. That's why I love working with real professional people. You always say a step ahead of me on the slides there, okay? Okay, so let me read that to you. For the people, this is for the people in the back, all the way back there, you may not be able to see it. We can all agree that the needs of the client must come first. This means that the counselor may have to be able to listen more than talk. This practice allows the client to, through guidance by the counselor, to discover their own solutions. The counselor should not self-disclose how they themselves overcame a similar problem in their recovery. In some cases, individual counselors like to talk more than listen and may end up using the client for their own self-gratification. Nobody in this room, but I know that that happens. Okay? Having said that, the field of psychotherapy, psychology, is not for everyone. Good listeners make good counselors. Okay? And that's
from you.
And that's cited as well. Okay? This is a quote. This is from the art book. Okay? What?
Yeah. Professionals are allowed to disclose to professionals.
Yes, that's true, Jimmy, but I got that from other readings I read, because I read a lot of research. A lot of these researchers that writing cite their own research and get themselves cited in my case. So I said, if they can do that, I can do it too. Okay, but the important part is, okay, so we were talking about the transference into working. You can't work out your own issues in the therapeutic session, okay? Making the right decision. So this is a decision that you're making. It's an ethical decision. The next step in the decision-making process is for the counselor to consider how, if at all, their personal feelings, bias, or self-interest might affect their ethical judgment and reasoning. So we have to question ourselves. Okay? What is the reason why we would self-disclose? What is the motivation for us to self-disclose? And I'm talking anything now, of the second question. What is our motivation for self-disclosure? Okay? And this is part of this ethical decision-making process that I have cited from Pope and Vasquez, who wrote this, how to make an ethical decision. Okay? Genuineness is the ability to be oneself and feel comfortable in the context of a professional relationship with a client. It does not imply a high degree of self-disclosure, but a genuine presence in the therapeutic relationship. Now, this comes directly from This comes directly from the OASAS Clinical Supervision Training Pack, okay? Now, genuineness is something that is important to me as a therapist, okay? Now, in this room we have interviewed thousands of clients and patients, okay? And I have found that the thing they want most from me is for me to be genuinely present in that therapeutic session. They want me to be present with them in that session, okay? And that doesn't require a high degree of self-disclosure. A lot of times I need to listen more than talk. Okay, but if you at all, and you can, I know you're all going to agree with this statement, if you at all drift off or say something that, like you haven't quite got what they say, or try to bluff them, or say something that you've drifted off and you're not present, they will know. They know. And you're going to damage the relationship if you do that, as you know. So they really want you to be present, and you have to be there. Genuineness is what they're looking for from you, especially if they're talking and spilling their guts out. Okay?
Yeah.
But you got to be a good listener, you got to be present in that relationship, and that does not require a large degree of self-disclosure to be that. That's very, very important. And I think that was on the exam as well. Okay? So this is part of the decision making. Sorry, do you want to say something? You're agreeing with me?
Yeah, but I was going to say, and if you do miss it, own it. Because they like sincerity too.
Yes.
Don't try to cover up with a power thing. You know what I mean?
No. Just be honest.
Yeah.
They want that. They want.
Say, I'm sorry, man.
Yes.
Yeah.
Sorry.
And refocus.
Okay, so the importance of role clarity and role integrity is this. So I was saying about that boundary setting, role clarity and role integrity. Okay? It was reported in White, here's citations again, 2006, that self-disclosure has become increasingly discouraged in the addiction counselor role. Okay, so let me read you the note. To paraphrase White, 2006, the use of self, using one's own personal and cultural experience to enhance the quality of service, has changed dramatically over the past 4 decades. In the paraprofessional era of addiction counseling in the 1950s to early 1970s, disclosing one's status as a recovering person and using selected details of one's personal addiction and recovery history as a teaching intervention were among the most prominent counselor interventions. Oh, I missed myself up there. This dimension of the counsel role was based in great part on the role these dimensions played in successful sponsorship within Alcoholics Anonymous through the 1980s and 1990s. In present-day professional alcohol and substance use disorder counseling, such self-disclosure has become seen as unprofessional and as a sign of poor boundary setting. So just I'm paraphrasing White here. There was a time when that was prominent. In the early days of the paraprofessional, and sometimes in EAP programs, and before people went to school, everything like that, that you would say, hey,
You're in
look.
recovery, a lot of times you can get a job. You got 2 years sober.
Yeah.
We're going to hire you for
And then you would say to patients, you can't get over on me. I know exactly what you're doing, But that's it's seen today as not paraprofessional. I don't know. Just speaking for myself personally. I have $140,000 university education. I don't want to all of a sudden just be like one of the guys. We'll just see how it plays out. Okay. So I'm citing other research here with this. Okay. Very, very important in our field. Very, very important. But I've been a former supervisor. I supervise an internship program. It's very important And I still have phone relationships with people that I've worked with over the years. Sometimes I need to talk to another counselor. I need to talk to another counselor to work out something that just took place in a session. You know, I need to speak with one of my peers, and we should all have somebody in our network of people that we can pick up the phone and talk to another counselor. Like, oh my God, I won't believe what I just heard. Something that affected me emotionally. But did I let the patient know that? No, absolutely not. Absolutely not. Okay? So, if there is even the slightest concern surrounding the question of self-disclosure for a counselor, they should seek consultation from their supervisor. So even if it came up, you wouldn't want to act on it until you spoke to a supervisor. Marcia Booker, licensed social worker in CASAC. This is from a personal interview of my own research that I did on the topic, because I've interviewed several people, several clinical supervisors, okay? Is the executive director, she's the executive clinical director of Interline Outpatient Services, Queens, New York. Ms. Booker was able to be succinct in her consultation for the specific situation being discussed in this presentation. So, I did my own interviews with professionals, but she was very succinct in her answer. Okay? I'm going to read you her answer. And this is also in your... You have the articles in your handouts. The handouts that come with this presentation, this is from the article. Okay? This is from the interview. I'm going to read it to you again for the people in the back. Ms. Booker explained that when a counselor discloses that they are also in recovery from addiction, the client will relate to their shared experience rather than the professional ability of the counselor to treat them. Ms. Booker went on to explain that the client will start to relate to the counselor as a peer. If in this process the counselor loses their professional status and lessens their ability to effectively treat the client, there is a loss of differentiation that can damage the therapeutic relationship. Therefore, Ms. Booker's clinical position is that her counselors and social workers who are also in recovery not self-disclose to their clients who are in treatment at Interline Outpatient Services. Okay, so what Ms. Booker is saying there is that who will be affected? Both parties. Okay, so with the differentiation, the patient sees you as this highly skilled, highly trained, highly educated, highly experienced professional person up there who can treat, who can help them. And based on the motivational interview, what we said, I can help you with that. They see there's an alliance there. I can help you with that. So if you self-disclose and there's a change in the differentiation where the patient starts to relate to you, you come down, this patient starts to relate to you as a peer, that affects the patient in a not great way. Okay? So therefore, based on that formula, you cannot self-disclose that you are also in recovery. Because it will affect the patient in a not a good way. Okay? Because it will lower your professionalism. Okay? Follow me on this. Follow me on this now. Okay? Yeah, I can see you with me on this. Okay? Adopt the perspective of your client now. Be the client. Sit on the other side of this. Okay?
Role playing.
Huh?
Little role playing.
Yeah, role playing, right. You're the patient. Okay? From the client's perspective, would you rather have your counselor in the role of a highly trained, highly educated professional? Like if I needed legal advice and I went to a lawyer, when I want the lawyer to be having a degree in law, where'd you go to? If I saw, so-and-so law school, I'd want to see that degree up there. If you go to a doctor, where'd you graduate? And I want to know that this person is a professional person that knows what they're talking about, right? Same with me. That's who I am. Then when they go to the office, that's what you get. Okay? That's what they get when they come down and sit down with you. So you're in the role of the patient still now, right? The client needs to see the counselor as a professional individual who has the knowledge and ability to effectively treat them and help them recover. That's what they see you as. Okay? That's what they see us as. And they need to see us as that. As the client, you would not wish to relate to your counselor as a peer, thereby damaging the therapeutic relationship. Okay? As the client. Okay? So, my notes on this are, from the client's perspective, this writer would rather have their counselor in the role of a highly trained and highly educated professional. The client needs to see their counselor as a professional individual who has the knowledge and ability to help them recover. As the client, this writer would not wish to relate to their counselor as a peer and thereby damage the therapeutic relationship. Upon careful review of this decision-making process, this writer, me, would be very comfortable in making a decision not to self-disclose, and I would. I would be very comfortable making the decision if the situation was that I was in recovery, or whatever it was. Whatever it was. Whatever their issue is, I can help them with it, whether I've been there or not. Right? Is that right? Yeah. I've done some great work with some young rape victims over the years. You know, these were young women who were raped when they were children, you know. Done some great work through psychodrama and role-playing for them too, because we have to address trauma, what we were talking about in our other training. To address trauma, I was able to allow them to address their trauma. And I was right there with them when they were doing it. But I've never been raped. I didn't have to be. They didn't have to be in that moment with them. To be genuinely in that moment with them. That they were, as I was there, it was a safe place. It was in my office, you know. And we addressed that. Okay? So was self-disclosure ever appropriate? Okay. In this presentation, we can report that not all self-disclosure is inappropriate. There are times when self-disclosure works, if it relates to information that the client may be stalled in understanding in that moment of the session. Okay? Or if it relates to what is taking place right at that moment. For example, if a client is revealing parenting issues, the counselor may self-disclose that they are also a parent, and often professional therapeutic insight as the counselor parent. And this I've done. So a parenting issue. I mean, I'm a parent. Okay? If you're a parent, you know what you're dealing with, you know. And I'm still dealing with it, you know. But so you might say that look, I'm a parent also, you know, to help them to understand, to resolving some parenting issue. So now I'm talking to them as a counselor parent, especially when it comes to education and school and things like that. My son, you know, at school at the end, they would say, look, do we have to call your father? He'd say, no, don't call my father, because I would go down there. I'd stop what I was doing, I'd go down there, and he'd show us, and I'd say, well, what's the problem? And I sat in the class with him. He sat there and I sat there. You know, and he knows, don't call my father, because he'll come and sit in the class with me. And I say, don't tell me you can't sit in the class, behave, because I just sat there for the 40 minutes with you and you were fine. So always go to school and go to class like I'm sitting next to you. Because if they call me again, I'm coming in and sitting right next to you. Don't call my father. You know, that's how. So I understand how it is to be a parent. So this is not to be confused with the argument that counselor self-disclosure aids client self-disclosure. Now, before I go to the next slide, I'll just give you the precursor for that. That by self-disclosing, you aid the patient in self-disclosing. That the patient will self-disclose more about themselves if you disclose more about yourself. Right? Okay. Wait, doesn't counsel self-disclosure aid, you know, client self-disclosure?
Not necessarily.
Sure. Well, you know, because I do the research doesn't show that.
Research.
The research doesn't show that. Okay? Here it is. We're on to state that. Although our evidence indicates that therapist self-disclosure can be helpful for treatment, it does not confirm the argument that therapist self-disclosure exacts its impact on encouraging clients to self-disclose. Now that's just the one that I included. Okay, so the research does not show that by the counselor saying, you know, disclosing that they've been through, if a patient is stalling or not self-disclosing or not opening up, that if you open up to them, they'll open up to you, okay? therapeutically, clinically, that is not effective. It's not. And the research shows, the studies show that, okay? And here it is, and that's just the one that I included. Counselor self-disclosure is not an effective therapeutic technique to aid the client to be more open and forthcoming. So let's just be clear about that, okay?
The focus is shifted. At
Yeah.
this point, the focus is
Shift-
shifted to the council.
On yourself, or in this case, on yourself. Yeah, on yourself, right. And the client will sit there all day. He'll sit there all day and let you talk about yourself. Really? And what did you do then? Really?
And I'm seeing.
And you put up with that? How long did that last for? They'll talk about you all day
All day.
long. All day.
As long as the focus is.
It's off of them. Off of them.
Redirect.
Right, and they'll try to do that,
Right.
especially adolescents.
Yeah.
You know?
And then they'll blow you up later on.
Yeah,
Yeah.
An example of that. And
Yeah.
because they're over there telling other guys about that. Hey, did you know, tell other people in the group, right? So
I
you
got
gotta
no
be
after you. You never helped me anyway. All you did is talk about you.
Yeah.
Oh, yeah, uh-oh.
And I use that as when I'm first meeting with a client sometimes. I say, so you've been in treatment before, how'd that work out with you? And they'll say, the last time I was in treatment, most of the client talked, the counselor talked about himself most of the time. Never listened to me. So I know that's a patient who needs to be listened to. Or they'll say, the counselor just sat there all the time, I did all the talking, never gave me any feedback. That's a client that might need a little more feedback. So they tell me what I need. But that could backfire on you when you do that, okay? Let me just read the note on this. Counselor self-disclosure exists and will continue to exist in the field of psychology and counseling. This Bridges 2001 points out that while most therapists engage in some form of disclosure, intentional decisions to share feelings and personal views with patients remains a complex area in clinical practice. So the draw to do that, to kind of magnet to do that can be difficult, like I was saying. It can be difficult to you want to kind of jump in. And this is the study here. They said that although, and it says that the evidence doesn't support that, the clients will be more forthcoming if you do self-disclose. Okay? This is a brief example as this, and this is part of almost like covert research that I did. What I did, well, saying this off the record, and I got it on film. What I did was, I submit applications for job interviews, and if I got a job interview, I would go to the job interview like I was there for the job interview, but really I was interviewing the program director to see what the practice was, the clinical practice was at programs.
Ah.
Covert.
That's what I did. I'd come show up at the interview, but I was really interviewing them. So this example will remain anonymous. Not like with Ms. Booker, she was a willing participant, and she knew I was interviewing her for this article, so she was more than willing. Matter of fact, I sent her a copy of it, and she said it was great because she practices this work for a long time, and that was the policy, clinical policy. So they actually see it in writing and the supporting documentation, which was good for her. Okay, so this is an example of true story. Okay. A client was having problems being shamed by her peers in the treatment program because she was still on methadone. Okay? The clinical supervisor, this is the clinical supervisor now, cleared a counselor who had also come off methadone to share this information with the client. Okay? The counselor disclosed this personal information in the session with the supervisor present. So the counselor went to the supervisor, or the supervisor went to the counselor that this patient had been shamed by some other, we'll say young women, but girls in this program. You're not clean, you're still on methadone, you're not clean, right? So, and they went to the supervisor said, okay, so she got the counselor who was in recovery and a counselor from methadone to share with the patient that I was on methadone too. And I know what you're going through and doing, right? Okay, so that was her clinical decision, okay? The counselor disclosed this personal information in the session with the supervisor present, okay? The supervisor explained to me, I got such a good feeling when I saw the relief come over the client's face. Okay, hold on. Okay, so let me finish the story. I can see where you can see where I'm going with this. Because the faces that you just pulled over here in this section of the room, I did not pull that face. I couldn't, no. I gave the poker face, and I'm good at that. Right? I'm good at that. Okay. Okay. This first client told 2 other clients who were shaming her that her counselor was also in recovery from methadone. So that patient, that girl, went and told the 2 girls who pointed the finger at him, oh yeah, well my counselor's also in recovery from methadone, so there. Okay? These other 2 clients spread this personal information, and within half a day, the entire client population knew that this counselor was a recovering addict, thereby compromising the counselor's therapeutic anonymity, which I said before, and professional ability to treat her clients, all unbeknownst to her. So she sat in group the next day with her group, and everyone in that group knew that she was recovering from methadone, and that the whole thing, and the counselor didn't know that everyone knew. You see how that can backfire?
Right.
See the damage that can be done? Okay, so let's just discuss that for a second, because I have this in the thing. So, let me just think now, what were the mistakes that were made? Okay, clinically, what opportunities were completely overlooked? And how could this have been handled differently? Okay, so what mistakes were made?
Supervisor.
The supervisor.
Motivation of the supervisor.
The motivation of the supervisor. Right.
Go ahead, Phil.
Okay, so clinically, what opportunities were completely overlooked?
Helping the client to
Yeah.
manage the feelings.
Okay, helping the client manage her feelings. And what were her feelings?
She felt shame.
She felt shame, right.
How to
Now,
handle that
right, exactly right. That's exactly right. The patient was feeling shamed, okay, which is an important feeling that would need to be addressed therapeutically. Why was she feeling shamed? Okay, what were you ashamed of? Is it the methadone, or is it something else? Okay, excellent. Go to the head of the class. Okay,
4.0.
4.0. Okay, I graduated soon. Okay, and I was valedictorian in my grad school.
Yeah.
Okay. And I'm a published
Okay,
author.
just one off.
And I'm a
Okay.
published author, that's right.
I'm suffering from shame right now.
Okay, so let me throw this out. As an undergrad, I received both a junior and senior departmental awards in psychology from Long Island University. So. Yeah. All right, so, okay, so you would want to address a feeling as strong as shame in your therapeutic session to why, where, when, how, what.
And how do you handle it, and when is this been?
Right. What is it based on? Is it something
Yeah.
else? There was some great therapeutic, great stuff. There was some great stuff there that was completely overlooked.
And
Why?
how she could handle it.
So the supervisor could feel good about it.
Right.
So she can feel good about herself. Oh, God. And this is a true story. I got to hear my.
Okay, so but what was the question? Why do you think the supervisor did that before they got the good feeling? Why do you think the supervisor?
Well, Jimmy, the supervisor's not in therapy.
Looking for
Okay? But I want you should get this other question, right? Okay? How could this have been handled differently? Or what mistakes, or what was missed? What was missed that could have been handled differently? And it actually, I want to go even farther than that. Farther than that. Anybody?
How did the counselor feel about disclosing everything?
Well, not from the counselor's perspective, from the client's
treat the
opinion.
client.
The treatment of the clients. Clients. Jimmy, you should get this.
More focused on helping the client to
Okay?
become assertive and take care of herself.
True,
Or
but I'm-
herself.
But I also would have brought the whole group. I would have brought that to the whole group.
Thank you, Jimmy.
Yeah.
Right, Jimmy's got it. Okay? I would have got the other two girls together. Why are they shaming that person? Why are they shaming that person? Okay, I would have got that. I would have got everybody together. I would have worked, yes, with the shaming, but I would have got my supervisor or somebody or myself. I would have got the other two girls and the patient and said, let's work this out as a group. Okay? Why did they shame her? I would give her the opportunity to tell them how they made her feel. By you saying that, I felt this. And I'm working out why I felt that with this. I felt that. And then I would ask them, I would work with them, why did they point the finger at her? Why did they shame her? And I would work that. And I have done this, especially where there's been some type of conflict or confrontation between patients. If there's been any conflict or confrontation or uncomfortability, or even in group with patients, I get everybody together, and believe me, they would have walked out of that room as allies. Because they would have understood what she felt, and they would have, the two other girls would have understood what they felt. And why did that take place? And this was an inpatient program. Inpatient residential program.
Yeah.
So you had the opportunity to do the work because they were there. Okay? But this is real, this is clinical stuff, and that has to do with what we were talking about before with trauma, addressing trauma. You know, that there's some real, what did you say, good stuff. There was some good therapeutic stuff, and that's the way I think as a clinician. And I put on my poker face for this, and I got home, I wrote this whole thing down when I got home, because I was kind of shocked, okay?
Yeah.
Now, I've been back to that program to do something else about some of the other trainings that I've done. That clinical supervisor is not there anymore, okay? Now, I don't know why, and I don't care why. But the person that's in there is actually somebody that I knew, and they're better off. They're better off. But this is the type of thing, you know, this is why I do these trainings, but this is the type of thing that I see when I'm out there. I mean, not everybody's, you know, on board with studying and researching and learning and coming all the way by train to come to Long Island, to come to a training, you know, and came from Brooklyn, right? And you're not going to hear this. You're not going to see this type of training anywhere else. Okay, so that was a little discussion on this, and you were all absolutely right. But you see where the next level is? Get everybody together. Let's sit around, do role reversal, get the teddy bears, you know, do what you got to do. What were you feeling? How were you doing this? Okay, now you be her, you know. They would have walked out of a session like that, like three sisters, allied, supporting each other in their recovery. That was what was missed. And we've done that, haven't we? We've done stuff.
That was an opportunity.
Yeah, great opportunity.
Right.
That's why I say, what was a mistake? What was completely overlooked?
Right.
What was completely overlooked? That was a great opportunity to do some good
Therapeutic.
stuff. I live for things like
The
that.
healing.
Yeah, healing. I did some good, it was a good healing opportunity. I live for moments like that. Okay? And it doesn't require a high degree of self-disclosure. It doesn't. We're a facilitator. I'm a facilitator. What does that mean? We facilitate to keep things moving along. We help things move along. We're directive. We're facilitators, moving forward in your recovery. And that was a great opportunity. Rick's right, it was completely overlooked. Okay, so. One might ask at this point, what could be the alternatives? Okay? Good question. The answer to this question is a challenging one. This was the example I used before. A client may say, you simply ask, are you in recovery too? Like all innocent, like, hey, gee, wow, you in recovery too? Or what do you know about addiction? How can you help? Everything you learned in a book. That was the one. You've heard that?
Yeah. I've heard that. I've had interns ask me, how do you answer this question, or how do you deal with this question? I've had clients come up to me, et cetera, and so forth, and say, basically, it's a double-edged sword. If I tell you that I am, then we've kind of ruined a therapeutic alliance, and you think, well, you managed to come through it, so I may have another run in me, because look how much younger I am than you. Or, how can, the other side of it is, if you say that you're not, then how can you help me, if you
Right.
learn? And what I tell them is, if I was looking for a heart surgeon, if I had a heart problem, and I'm looking for a heart surgeon, I don't care if they have a heart problem or not, I want to know that they can help me.
Absolutely.
And that's kind of what I throw out.
Absolutely. But you're right, it could backfire on you because they say, okay, yeah, but then they're telling their friends. And the next thing you know, they're going to say, what the hell do you know? Look, you're just another addict too,
Right.
You're just an addict too, so how, what the hell do you know about anything like that? Or, maybe I can have another run in me, okay? Look, you turned around. Well, I'm not ready yet. I'm not you, So it can be dangerous.
Right.
It's dangerous.
But you know what I tell them with the interns, because we got a bunch of interns, they're not addicts, you know what I mean? But I'll be telling the clients, I go, listen, here's one thing they can tell you is how to live without using drugs, because they know.
Mm-hmm.
They don't use drugs to live.
Okay.
And they got a great amount of education to help you do that.
Mm-hmm.
And then they look at me like, well, I
Right.
go, they can tell you how to live without using drugs. You don't know how to do that. Why don't you ask them that?
Yeah, how did they get this far into their life without using drugs? Maybe they can give you an answer to that.
Someone told me that. I wish I had, you know what I mean? Because I go, what good information. Just to disarm them,
That's a form of deflection when they do that. Okay? Stop saying okay. The council must invoke an alternative response other than self-disclosure. Have a prepared response that returns the focus of treatment back where it belongs, back onto the client. So that's a deflection when the patient will say, are you in recovery too, or what this,
Right.
that's what, you, that's what they want. Let's talk about you, let's not talk about me, let's talk about you, okay? It's a deflection. So you want to have your responses ready in advance, okay? Just remember this. Clinicians repeatedly encounter dilemmas for which a clear professional clinical response can be elusive. Standards and procedures cannot take the place of an active, deliberative, and creative approach to fulfilling clinical responsibilities. Being prepared in advance and having a decision-making process in place is important because in the human services and healthcare industry, these situations may arise without warning and may need to be addressed fairly quickly. Okay? It's without warning and fairly quickly, and they will ask you when you are your most vulnerable too. Okay? Therefore, know in advance that you are going to be challenged by your clients in regard to these questions. It may come as a deflection whereby the client is deflecting the attention away from themselves. Do not be fooled. Be prepared in advance with your answers, and I'm going to give you some suggested answers and we can come up with a couple more. Okay, so you want to be prepared in advance because know that it's coming, especially with adolescents. Okay? They're going to look to challenge you when you're not ready. Okay, but anybody will. You know how it can be. I'm not going to say the addicts are manipulative, but they will know when to throw your fastball at you. Okay, so you got to be prepared in advance so you don't want to do that. Okay, so here's just a couple of alternatives, possible alternatives, right? This is not about me, it's about you. How can I help you to develop a recovery plan that works for you? So I'm here, okay? I'm sitting in my chair, okay? So they just asked me that question. I'm sitting in my chair and I'm saying, this is not about me, this is about you. How can I help you in your personal recovery?
And then we know if you're in recovery or not.
That's a rhetorical question.
Yeah, I'm just giving you back some of the responses they said.
I know. I got that coming. That's coming after. Okay. Go ahead, Peter.
Probably respond and think it's like, oh, how can I trust you if you're not going to be honest with me?
Okay. So, what is that? What's the stuff behind that?
Right.
What's the stuff behind that? It's a trust.
Right, I was saying, so how many
Trust me,
times have you been betrayed or how many?
Right. That's a lack of trust on their part. So they have been betrayed. They have not trusted somebody, usually a parent or a brother or a family member or a girlfriend or something like that. They've been somehow betrayed. It's a deflection to get the focus on you, and quite frankly, it's BS. Okay, it's smoke. They're blowing smoke. Okay. a lack of trust issue, so you want to, that's a patient that needs to work on developing trust. And how you develop trust is by being a trustworthy person, okay, because you know that they can trust you, but they are not so much of a trustworthy person. So you have to teach them, and that's an issue that I would address with them so they can learn how to trust themselves, trust their own decision-making process, not trust me. This is about me, this is about you. Okay? How I got here is not important. What is important is how you got here, and how can I help you move forward in your recovery. Okay? So I'm ready to my answer now. How I got here is not important. What's important is how you got here, and how can I help you. How can I help, like we did with the motivational, right? What do you want to work on? Not what I want to work on. What do you want to work on? How can I help you move forward in your recovery?
I want to work on you.
How's your response?
She's ready to respond. Yeah.
Respond.
Yeah, she's ready to give you some attitude. This is just have something ready. This is just to get, these are possible alternatives. Have something ready. Because what you just said, I need to know that I can trust you. How can I trust you? They're going to come back with that. Come right back at you with you. Okay? What is most important is how the client came to be in that seat, not how the counselor came to be in their seat. Because you know how I came here. I got my college, I got my degrees, I got my education.
I got hired.
I got a job, you know? Or this strategy will turn the focus back onto the client and make their recovery the primary objective of treatment. Okay? So you constantly want to be putting the focus back onto the client. Okay? And you want to have something ready. Your own. Come up with your own. Okay?
So we could be better manipulators.
I suppose you could do that.
I always ask them, how are we disclosing,
How is that gonna
will
help
help
you?
you with your recovery process?
I can identify with you.
Yeah.
But I was thinking when you said that before, if I said, yeah, I'm in recovery, you know what I mean? Well, how much money you make? You know what I mean? Like, they're going to want more information.
Yeah. You married? You married? Your wife in recovery too? Did you marry someone? Because I thought you weren't supposed to date people in the program.
Because I started cheating on my girlfriend. You ever cheat on your wife? You know what I mean? Like, I need disclosure. Identify with me, man.
Right, you don't make a floodgate. Woo!
Did you use student? Well, how much did you use?
Yeah.
How often? How much
Oh yeah, I know.
What did you
Yeah.
do?
Where did you come?
intake
Oh,
on
you used to
you.
go to Manhattan, where? Uptown? You know, I used to, it was 117
You know,
street.
any
You know,
place to
you-
score, right?
Oh, you never shot dope? You can't help me.
Yeah.
Oh, you're worse than me. Forget it. I can't.
I
Still reflects something.
All right, in conclusion, therapists and counselors may self-disclose in other areas when therapeutically advantageous to the client. Okay? However, the disadvantages as analyzed herein, even any perceived disadvantages, so any disadvantage or even perceived, it could change the differentiation. It could, okay? Even perceived disadvantages to the homeostasis of the therapeutic relationship far outweigh any possible advantages that counsel self-disclosure of their recovery might offer, even if it's perceived. Okay? Not that it could happen, it could happen. And somebody said, this came up before I click onto the next slide, peer support and the peer relationship and peer support is a very healthy relationship to have in recovery, okay? And that peer support of relating to someone as a peer and their shared recovery exists and is very, very strong in 12-step programs, okay? So, to have that relationship, you don't want to have that relationship with the patient. You are in the client-patient relationship. They need to have that relationship in one of the 12-step programs as support of their recovery. Okay? So we have to differentiate our professionalism between treatment and 12 steps. So I strongly encourage patients to attend 12-step programs. And like we said, not just this or that, everything. Therapy, counseling, prevention, management, Dr. Love, medication assisted treatment like that. That is a strong component and it's healthy and working very, very well in 12-step programs.
I have self-disclosed to clients by saying, but they don't know that I'm self-disclosing. You know, I had a client once with a similar issue, or I had a client once who struggled with something very similar.
Yes.
I didn't have that client. I might have been that client.
No,
They
you
don't
never
know
should.
that.
You're talking about
That's not
yourself.
self-disclosure.
Well,
Yeah.
it is in a way.
No, you can give first-hand information,
Secondhand.
second-hand,
Right.
from a second-hand perspective, like that has happened,
Right.
or you know, this is how this person overcame that, but it's really you, but you're not telling them it's you. That's okay. There's nothing wrong with that. You want to use all your tools that you have as a therapist, as a counselor.
Right.
You want to use that, and if that's a tool that you know what they went through, and that's what was needed in that situation, because that was something that existed right now in that moment, then you could say that in the third person. That's okay. That's one of your tools.
Right. But yeah, I tell the clients, listen, you don't have the corner market on abandonment, rejection and stuff. People deal with that. Your problem is when you deal with that, you can't stop.
Right.
They can.
That's good.
Yeah. But you're not unique that you're suffering from this. Everybody has abandonment, rejection,
Yes.
issues and
Yeah.
stuff that have been hurt.
When you're in it, you think you're the only one that's in it.
Right.
You're not. You're not. There's plenty of other.
And
That's
so-
why group therapy is great. That's why I
Right.
love running group. Because the people that come to treat you, know, these things like that, you put them in a group and you get them in another couple
Yeah.
of weeks. They're not really understand. I went to that last Thursday.
Yeah, you're not unique.
But that's also sort of self-disclosure too, because you're saying, well, if everybody has abandonment issues, you're saying, I'm part of everybody, so. you know, that's-
Others,
Other people.
not every, not critical things
Many
don't
people.
overgeneralize. So you couldn't have.
Well, a lot of times I'll tell them I work with people down on addicts that have the same issues you have.
That's good.
Yeah.
That's a good one. Yeah. Because I work with people that aren't actually just, cognitive behavioral psychotherapy. They're doing something else, some other issue, there are other issues that people have. Does that answer your question, Pete? Okay, so the professional challenge. Therapists and counselors who are also recovering addicts and alcoholics who wish to be considered professional and effective should not, under any circumstances, self-disclose to his or her clients that they are also in recovery. Just a second.
What is that?
The new question you have to need to ask yourself is,
It's a big one.
are you up to the challenge? So when I said it was a challenging question and you didn't want to answer number 4, because these, I mean, sometimes it's raw stuff that you hear. But it's not to tell or not to tell. It's the question is, are you up to the challenge here? Okay, I'm not telling. Okay?
Sure.
All right, so again,
Don't like magic sticks.
I just want to get something else as part of that on there. That you've made it in the publishing field when someone writes an article about your article.
Right.
So, as far as full disclosure goes, I've included that in the printed handouts. Okay? Now, they wrote an article about my article, and they are, you can read it and see, because they originally take the position, because if you look at them, there's a couple of guys that have been around a long time, and I challenged them. It was a challenging article, just like this is challenging. But you see, as you read into it, they actually are agreeing with me. They're in their own way to say, well, where I'm saying not at all. And that's not just me, there's other clinical supervisors, and I can name several, that's the policy of the program. You do not self-disclose, okay? So they're saying something else, other than that, but when you read into it, they actually are agreeing. They are agreeing with me, okay? So they may not have intended to do that, but that's my story and I'm sticking to it. And that's included, in the printout and the handouts as far as this presentation goes, okay? All right. Okay, and that's it. Thanks very much.
Question statement.
This training course was presented by the Institute for Learning and Development. For more information, here's the website, the webpage, which I'm going to give you that. So if anybody has any questions, you can email me from the webpage, and I'll be happy to answer them. But while we're talking about the webpage, just let me give you some information on that. It's www.imustnotuse.com. There's several free information and trainings and free information for clinicians or anybody who's interested in recovery, right? Self-disclosure and addiction counseling, to tell or not to tell. This is my first publication. I'm a published author, so the article, the publication is there. I've published twice. The No Matter What Relapse Prevention Workshop, Recovery Training for Effective Coping Responses. This is a free downloadable workshop that I wrote for patients to kind of like a homework assignment that they can click their way through it and watch it at home when they're not actually in group and treatment, to give them a little something to do, an assignment to do that really teaches them effective coping responses. And then I have my film, The Whole, a story of addiction, relapse, and recovery. This is about a man who lives his life as if he belonged in a dirt hole. And it's really a composite of all the clients I've worked with in group over the years, where they said they feel like they're in a hole and they can't get out, or when they get out they go back in. It has to do with relapse. But you can show it to your clients. I showed it to the patients to elicit a discussion on relapse prevention, and I always got a response. You'll get a response from your patients if you show them the movie. Okay? So please, visit the website. There's free information there. This is my copyright notice. This course is copyrighted. Of course, you have it here on video, and you have the CD package. It's just that it is copyrighted, so I don't want to see this for sale on eBay. Okay? It's copyrighted, not for sale on eBay or anywhere else for that matter. Okay? Now, if anybody has any questions, I'd be happy to answer them. You can send me an email through the webpage. It's no matter what at imustnotuse.com. That's the email address. No matter what at imustnotuse.com. And the webpage is imustnotuse.com. And thank you very much for sitting and taking this very, very important training for the future.
Thank you.